Before we get into structure and models, I want to start with the scene many of us have seen in one form or another. It is late in the afternoon. The clinic day is winding down. The waiting room is quiet. Chairs are empty. Lights are starting to dim. The clock on the wall reads 4:58, and a door in the hallway is already nearly closed for the day. Outside, a parent stands with a stroller. The sign on the glass says closed at 5 p.m. There's no frustration shown, no raised voice, no one demanding to be let in. Instead, there's a pause. A parent is thinking, coming back tomorrow means calling out of work, rearranging childcare again, figuring out transportation again, and risking income they depend on. A few minutes on the clock becomes the barrier to care. Mind you, this is not neglect. It is not indifference. It is circumstance. Scenes like this play out in cities and towns all around the world. Not dramatic, not loud, just quiet reality of people trying to access care while life makes it difficult to do so. For those of us in healthcare, moments like this stay with us. They remind us that access is not only about service offered, but whether life gives people room to reach them. When care exists, yet daily reality keeps someone outside the door, we have to ask ourselves a hard question. Have we fulfilled our duty? That question sits at the center of what we are here to talk about today. Thank you again for joining us. I am J.O. I'm the Vice Chair and the Chair of Ethics at GHQA. Today, we will consider ethical access to care through community-based clinics. Our focus is on practice, not theory. The goal is to let ethical principles become visible in the places where patients live and work. Ethical access affects real people with real schedule, limited time, and competing demands. When individuals delay care because clinic hours conflict with employment or responsibility, a structural gap exists. Healthcare is not defined only by what we offer. It is also defined by whether people can reach it. Ethics meets delivery when intention becomes action. Service not accessible in practice remains incomplete. The essential question is whether we meet people where they are or require them to meet us where system feels most comfortable. At GHQA, we have Code of Ethics and Professional Conduct. Our Code of Ethics calls us to integrity, competence, confidentiality, respect for diversity, and transparency. These are not ideas we frame on the wall. They are lived responsibilities. They show up in how we are present with people, how we listen, and how we follow through. Ethical care does not wait for avoidable harm or for someone to fall through a gap we already know exists. It moves toward those at risk and meets them with intention and consistency. Our bylaws and governance structure supports ethics. Bylaws exist to protect fairness and continuity. They keep decisions from being shaped by preference or convenience only. When structure aligns with mission, service becomes durable. Access barriers persist even in well-resourced regions. Meeting patients where barriers remain honors dignity, supports continuity, and strengthens trust. Awareness of a barrier creates responsibility to address it. So the Community Sunday Clinic exists to reach communities where they already gather. The model is straightforward: free care offered consistently by qualified professionals in accessible settings. Licensed clinicians and trained volunteers provide medical assessment, mental health support, health education, and referrals on Sundays. This work complements hospitals and clinics by serving hours and spaces where access is limited. The approach is simple. Identify a community setting, staff it with licensed clinicians, provide consultation without cost, guide patients toward ongoing care pathways, maintain realistic scope and consistent delivery. Simplicity improves access. This is what we offer. Service includes preventative checks, chronic condition monitoring, education, and coordinated referrals. We also support professional development and supervise student participation. The goal is steady care, not episodic charity. So the first year, we plan to establish 2 to 3, maybe even 5 pilot sites, serve at least 2,000 patients, and train 50 volunteers. We will track visits, referrals, and follow through. Ethical practice requires measurable accountability. So why does all this matter? Healthcare access reflects ethical priorities. When care remains out of reach for working families, delivery models require adjustments. A system that serves only those with schedule flexibility and financial security lacks fairness. There are some ethical guidelines I would like to offer. We do not need to reinvent global ethics. These are guidelines as we start this project. The first, who we serve. No one is screened out because they are inconvenient, uninsured, undocumented, or unfamiliar with systems. Presence before paperwork. Second, how we practice. We offer evidence-based care, clean boundaries, privacy is respected even in borrowed spaces, continuity through referrals. Help, do not promise what you cannot maintain. Thirdly, how we relate. We listen first, respect culture and language without presuming understanding. Treat every encounter as a moment of human dignity, not charity. Fourthly, safety. Licensed clinicians operate within scope. Clear protocols for emergencies. No medication storage without compliance. Report concerns through a trusted internal channels. Fifthly, stewardship. Transparent resource use. No informal donations handled personally. Partnerships disclosed. Sixthly, accountability. We record visits securely, even if minimal. Follow up when promised. Regular reviews of practices and outcomes. And we invite correction, not only praise. 7, boundaries. Church basement, mosque classrooms, school gym, community hall, same standards as a clinic. No proselytizing tied to care. We support faith. We do not leverage it. And lastly, humility. Know when to refer. Know when to say, I do not know, but I will help you find someone who does. These are principles. They sit before policies. So we encourage anyone to get involved. Clinicians, community partners, and supporters are invited to participate. Few hours of service each month may prevent avoidable illness and hardship. Contributions may include clinical skills, space, or logistical support. We're grateful for our current partners. This work builds through collaboration. So those that are interested in involvement may contact us directly. Here's the information that you see. Shared commitment strengthens reach and sustainability. In closing, let us briefly return to the patient outside the clinic. They did everything possible. They showed up. The system did not. Our role is not to judge circumstance. It is to respond to it. Ethical commitment gains credibility when it becomes accessible. This model reflects a duty to secure dignity and care for every community we serve. Thank you for joining us today.